The following podcast is part of a certified educational activity titled Decoding Biomarker Testing and Targeted Therapy in Non-Small Cell Lung Cancer, the complete guide for 2024. Access the entire activity and complete the post-test at peerview.com/TFK860. Downloadable slides and practice aids are also available.
Well, hello, good evening, everybody. Welcome to Decoding Biomarker Testing and Targeted Therapy in Non-Small Cell Lung Cancer. This is the complete guide for 2024. My name is Stephen Liu. I'm a thoracic oncologist from Georgetown University, and myself, as well as my esteemed faculty here, will walk through all of the essentials for targeted therapy and the treatment of non-small cell lung cancer in 90 minutes. So get ready. Really graced by tremendous world leaders here on the stage. To my immediate left, Professor Solange Peters from University of Hospital of Lausanne. To her left, Dr. Jessica Lin from Massachusetts General Hospital and Harvard Medical School. And on the far left, Dr. Benjamin Levy from Johns Hopkins University. We're going to talk about biomarker testing. We're going to go over all the relevant targets and targeted therapy, a field that's moving at breakneck speed. Our goals for today: augment your knowledge about the ever-expanding spectrum of genomic alterations and targeted therapies, equip you with the essential skills to conduct biomarker testing, and to enhance your strategies for multidisciplinary and patient-centered care to improve outcomes in non-small cell lung cancer. I want to acknowledge LUNGevity as our partner. If you go to lungevity.org, you can access survivorship and support services for your patients and their care partners. These are wonderful resources to have in your clinic for your patients. They make explanation a lot easier and serve as a great resource for both patients and their caregivers. Let's get right into the program. We're going to start with how to optimize biomarker testing and interpretation of those results. All right, so we know that lung cancer is not one disease, a family of diseases that happens to start in the lung. And for decades, we've appreciated the difference between small cell lung cancer and non-small cell lung cancer. But if we look at the right, in the current day and age, we know that within non-small cell lung cancer, there are many different related but different genomically independent types of cancers. And these underlying driver alterations define the biology, and I think most importantly, they guide treatment. If we look at some of these CT scans, we can see the power of targeted therapy. These are all patients that I saw in my clinic in the past few weeks. We see rapid responses, deep responses, intracranial responses, and importantly, many of these driver alterations, while they respond very well to targeted therapy, they don't respond as well to immunotherapy. Now, there are some exceptions. KRAS, for example, some debate about BRAF MET, but for the most part, immunotherapy not as active as we'd like. Targeted therapy really our preferred option. So when we look at these alterations and the wealth of options that they reveal to our patients, in order to offer these to patients, we have to know their status. Here's just a list of some of the approved therapies by the FDA and their targets in lung cancer. These are only options for patients with EGFR-mutant lung cancer if we find that EGFR mutation. So let me start the program by throwing things to Ben. Ben, can you walk us through how we test?
Yeah, I think we've had incredible advances in testing and for the better for patients and for the clinician who's trying to select genotype-directed therapies. I think it's important to remember that the NCCN recommends broad molecular testing. You know, you look at single gene techniques like IHC, FISH, MSI, and PCR. I think this has gone to the wayside for the most part, as we now have, we've certainly got multi-gene techniques, and I think that the buzzword here is next-generation sequencing or broad molecular profiling. We know that not all next-generation sequencing is the same. We need to remember that this needs to include both DNA and RNA. This is really critical for identifying potential genomic alterations that we can wed to particular genotype-directed therapies or targeted therapies. And there are other things that are important. Certainly, tumor mutation burden may or may not play a role in the selection of therapies. And then something near and dear to my heart, of course, liquid biopsies. This is ctDNA that's shed from the tumor that you can now interrogate with 10 cc's of blood. So really moved the needle quite far in the past 10 to 15 years. Again, I mentioned this, proper biomarker testing matters, and we know that DNA is not enough. I would just whittle this slide down to the idea that RNA is needed to capture fusions, and we know that this is important for many drug selections. So Keep in mind when you're reaching out and trying to figure out which commercial company you're going to use or your in-house assay, it really needs to include both DNA and RNA. And then, of course, we could go on and on about liquid biopsies in lung cancer. I think we now know from multiple data sets that if you add a liquid biopsy to tissue, we are more likely to capture genomic alterations of interest. We know that tissue is imperfect. I think a positive result in blood tells you for sure you can go forward with a targeted treatment. I tell my fellows blood is truth. I think negative is important. If you have a negative sample, that doesn't mean the alteration's not there. You just need to keep looking for it in the tissue.
I think the advantage of liquid is it does come back a little quicker.
Yeah.
So in your practice, Ben, are you doing them sequentially? Are you doing both at the same time?
I think my practice has evolved over the past 5 to 10 years. We're doing them at the same time. I think everyone who comes in, we know, again, at turnaround time for tissue, it's a great point, 15 days sometimes at our institution. That liquid comes back quite rapidly, and we can make treatment decisions based on that result alone.
Solange, difference in Europe?
Yes, and you have on the slides the ESMO guidelines, and they were perfectly written because Europe is more conservative, but also to address the anxiety of the European colleagues who were not able to do the two, I would say, methodologies, liquid and solid, in parallel for reimbursement and accessibility concern. So the guidelines just makes a kind of hierarchy in how you should test these patients. Of course, the guidelines consider ctDNA genotyping at resistance or at initial diagnosis as being to consider, right? Can be considered complementary or alternative to tissue. However, they explain that it might make you gain time, of course, as compared to tissue. However, and might also avoid some invasive procedure. And we really restrict this liquid biopsy, liquid diagnostic to this situation where it's risky, difficult, and so on. So we prefer the tissue in Europe. Caution should be kept because ctDNA assays will miss histological transformation changes to small cell. ctDNA testing might not have adequate sensitivity to count the copy of a gene like MET, for example, and you might miss the rearrangements, the RNA changes, what we really call the translocations, and you might miss up to 40% of them. So we say, yes, you can consider, but only in the case it's only bone or it's difficult to access, and there are all these limitations. So you have understood that Europe is maybe not ready to replace the tissue by liquid biopsy. For many reasons, we are slower in that.
There's so much nuance here and just experience. You mentioned bone not reliable, negatives because of the decalcification process, but all these details, really the oncologist of today needs to be in some ways a pathologist. And Jess, we talk about the importance of testing early and waiting for those results because the sequence of treatment really matters in lung cancer. A little bit of a different paradigm. Can you explain why?
Yeah, so a key point here is that it's really important to send off the biomarker testing from the get-go when the patient has the initial diagnosis of advanced lung cancer, and that is the current guidelines. And the reason is that it really guides how we select the initial first-line therapy for patients, right? It helps us select the targeted therapy when there is an actionable oncogene driver that is present, but also to deselect immunotherapy. We've learned the lesson the hard way that when patients receive immunotherapy first while the biomarker testing is pending, for example, or before it is sent off, and then they switch to targeted therapy because an actionable oncogene driver is subsequently identified, there can be augmented toxicity. We've seen increase in rates of pneumonitis. We've seen increase in rates of liver toxicity, really diffuse severe rash. This is true with concurrent use of immunotherapy and targeted therapy as well. A key example came from the Totten trial. There was an arm where patients received osimertinib, EGFR inhibitor, together with durvalumab, and the trial actually had to terminate early because there was such a high rate of pneumonitis. And so it's really important to send off the testing as soon as possible and wait for the test result to come back before you're putting patients on immunotherapy because there is that added risk with sequential TKI exposure.
Do you find that hard to do? Patients often have had a diagnosis for a while. They want to be treated yesterday. You're going to say, we're going to wait a couple weeks for these results. How receptive are patients to that?
Yeah, so when patients are symptomatic from a heavy disease burden, that's when it's really hard for them to wait, right? In those cases where patients do need to start on therapy urgently because of symptomatic heavy disease burden, those are instances where I might use chemotherapy, one cycle chemotherapy while the biomarker testing is pending without immunotherapy so that you avoid that excessive risk. In the asymptomatic case, or if the disease burden is manageable, then when you explain the rationale for biomarker testing, I find that actually patients are able to wait for those results to come back.
Ben, difficult discussions to have, but you worked with LUNGevity on a discussion guide to sort of help through that process, right?
Yeah, I think this is a nice algorithm here. I mean, it's a little detailed oriented, but the bottom line here is that we need to, one, make sure we're doing comprehensive genomic profiling on all of our patients, maybe even our squamous cell patients. I think that's important because we know that those patients may still have genomic alterations. And the second point here is that liquid needs to be integrated into the diagnostic algorithm for these patients. It cannot be ignored. We know that, again, using it can rapidly give you a result and can more likely unearth an alteration in lung cancer that can get the patient started on treatment.
So we need to test everyone with lung cancer early, quickly, comprehensively, using the right technique. It matters. It guides our treatment. Solange, do we do a perfect job on this?
Unfortunately not. We are all convinced, one method or the other one, that you need to have these alterations on the left-hand side to be tested, and we will cover it later on. All of this list in the table should be tested in all patients frontline. And the percentage is the reality in the US environment, a large number of patients of this test being performed. But this is one by one. If you look at all of them are never being performed, or less than 50% of the patients have all these set of tests being done as it should be in the US, not in another country in the US. Interestingly, now we also test in early disease, and the implementation takes even more time. So we have some genes to test, but we still don't in half of the patients. So basically, one by one, they're not tested. As a whole, they're even less tested, and not in early disease when you can cure patients. So that's very difficult to understand. One thing is really education. Education is about how it's important, why it's important, is what we do today in order to convey this message. The second thing is perception. Perception that chemo is still maybe the good way to move, or chemo IO for everyone. So perception is wrong. Chemo IO is not the way. And last but not least, there might be some environments in which accessibility or availability to this modern treatment, the new TKIs, might be limited, and a contra, I would say, intuition or something which is a blocker and a prevention to really move with innovation. But all in this, we really have to move in a better education and improve that. And in Europe, it's even worse than in the US. We know we have this scale, it's called SCAT. It's a way to measure how much one of these genes is actionable with a good drug, right? And as you can see here, the SCAT tier 1, this is the list of of biomarkers I have shown before, means that the highest level of actionability you can imagine. So you have the biomarker and you have wonderful drugs. So when you look at these biomarkers on the right-hand side, yellow means they are tested in all these European countries, and orange and red means basically not or only in research. So only some of them are tested, even if they are highly actionable. And in European countries, I must say, most of the time, the drugs are accessible, really meaning it's about education. And you can make the same exercise not only in lung, but in breast, in GI. And again, as soon as you move with more than one gene, more than one immunohistochemistry, more than one fish, kind of NGS, for example, you get into the orange-red. So single methodology, simple test, you can have access in Europe. As soon as you go with multiple gene testing, it becomes very limited in Europe. So really something to address in the single gene, multi-gene. You can see the change in the color here. In the US, something which is probably more easy to describe as compared to Europe, because of the various countries which compose Europe, is the problem of disparity. What has been nicely shown is while the prevalence, for example, of ALK and ALK rearrangement and EGFR mutation is the same in Black people as compared to white patients, the testing is completely different. The real-world practice shows that Black patients are way less likely to be tested for one or all of these biomarkers. So basically, they are likely tested, less probably tested, which means that they have a lower probability to be included in clinical trials, because the reason why patients are included in clinical trials, one of the main reasons, if they are tested for all these biomarkers. And that makes sense, because this is the sorting machine between immuno and targeted therapy. So they are not tested so that they are not eligible for clinical trials, so that they have no access to innovation. So that's a real bottleneck.
Yeah, I think the disparities are something we have to address. It's really inexcusable, and there's a lot of bias, I think, that goes into offering testing or ordering testing. Certainly something we need to raise awareness to. Testing is critical. This is not some optional ivory tower test that you do to get a little more information. Without the right biomarker testing, you cannot choose the right treatment. It is impossible. And in 2024, there are right and wrong treatments. There are right and wrong orders of treatment. The stakes are really high. We need to make sure everyone's getting the testing because we have some brilliant options to choose from, which we're going to go over next. We're going to go right into our next section, selecting, sequencing, maximizing the benefits of targeted therapy across stages. We're going to start with what started targeted therapy, the whole paradigm, and that's EGFR.
Before we start with the therapeutic strategies that have evolved, we need to remember that there are different subtypes of EGFR mutations. Of course, the classical EGFR 19 and 21, the L858R, that are the sensitizing mutations, but we have the uncommon alterations as well, where other TKIs may be more reasonable, like afatinib, and then the exon 20, which I think we'll tackle. But clearly, like some alterations, not all EGFR mutations are the same, and it underscores the importance of looking closely at that next generation sequencing report to make sure that you're wedding the right therapy to the right alteration. As I mentioned, the world was quite simple up to about 6 months to a year ago, and a very easy decision. We had FLORA that showed that osimertinib improved response rates, progression-free survival, and most importantly, overall survival when you compared osimertinib to a first-generation TKI. So clearly, this was a landmark study for us. It was practice-changing, and it cemented, at that time, osimertinib for the standard of care for patients with sensitizing alterations. Clearly things have moved along and made things more complicated. That complexity is, of course, wedded to enthusiasm because we may have more options, but FLORA-2 was a study that tried to answer a simple question, which is, if you add chemotherapy to osimertinib, how does it perform versus osimertinib alone, the standard of care, specifically, again, for patients with sensitizing alterations, for EGFR alterations. And what we saw was an improvement in progression-free survival. This is the curves for both investigator assessment and BICR assessment, showing that you see that coveted space between two curves, that white space, showing an improvement here. And we're seeing ticks towards overall survival. We don't have this data yet. It's immature. We are all eagerly awaiting to see if the addition of chemotherapy to osimertinib, specifically carboplatin pemetrexed or platinum pemetrexed, is going to improve overall survival. Right after FLORA-2, we had MARIPOSA. Again, using osimertinib as the control arm here. And this was a little bit of a different strategy. This was a chemo-free strategy of using amivantamab, which is an EGFR-MET bispecific antibody, combined with lazertinib, which is a third-generation TKI, very similar to osimertinib. Again, looking this at frontline for exon 19 deletions and L858R. And once again, we saw an improvement in progression-free survival. So both chemo-OC, for those of you who missed it, and AMI-LAZ, both amivantamab, lazertinib, both improved progression-free survival. So we saw progression-free survival benefit here. And again, we're seeing some early ticks for overall survival. I think the big question here is, and I don't think we have time to review it all, is that the amivantamab lazertinib does have a set of toxicities that may be different than osimertinib and maybe a little bit more difficult to give. But again, we do see a benefit here in progression-free survival for both chemo-OC and amivantamab lazertinib. We've got a lot of new data coming up. I think this is hot off the press. Just briefly, subset analysis of patients from this MARIPOSA study, looking at these patients with poor prognostic features or patients who may not do as well historically, patients with liver mets, patients with brain mets, patients with co-alteration of P53. This is a subgroup of patients that don't do that well. We saw that the benefit held up in patients that received amivantamab lazertinib versus osimertinib. The RAMOS data, this is looking at the role of anti-angiogenesis combined with osimertinib, ramucirumab combined with osimertinib versus osimertinib alone. And again, this is a small study, randomized study, but we're seeing a PFS benefit with the addition of anti-angiogenesis to osimertinib compared to osimertinib alone. And other data that's come out at ASCO looking at the IV lazertinib, IV amivantamab plus lazertinib compared to sub-Q amivantamab plus lazertinib. This is a study looking at this in the second line in refractory EGFR-mutant advanced non-small cell lung cancer, and asking the question: does subcutaneous amivantamab how does it compare to IV in terms of toxicity and outcome? I guess this is the data we saw. We saw sub-Q IV amivantamab looking at IV versus sub-Q. It seemed like there was a benefit with sub-Q in terms of duration of response. And interestingly, sub-Q amivantamab seemed to portend better outcome than IV amivantamab. So we'll have to see how this pans out, but certainly maybe a better tolerated delivery of the drug and potentially better outcomes for these patients. Paloma 2, again, is another study that's subcutaneous amivantamab and lazertinib as first line in patients with EGFR advanced non-small cell lung cancer. This is the results of the phase 2 Paloma study. We've got data that was presented today looking at amivantamab plus lazertinib in patients with active CNS disease that are EGFR mutant. We're seeing response rates that are competitive. The intracranial response rates for both brain met cohort and leptomeningeal cohort, 40% and 23% respectively. Proof of principle that this drug may cross the blood-brain barrier. And then,
This was just an hour ago, literally, and we're seeing leptomeningeal space is really an important place for development. That 8-month period of time on treatment, I think, is pretty impressive. So it's great to see this space being developed more. Ben, am I understanding you right in that osimertinib alone was our standard? Now we have osimertinib chemo, FLAURA2. We have amivantamab lazertinib, MARIPOSA. Are you saying that both improve PFS over osimertinib?
I'm saying that. I'm saying that both improve progression-free survival. And I think the end of the day, just to be very brief, it'll all come down, Stephen, you've heard me say this many times, is the juice worth the squeeze? We see these benefits, but our toxicity is going to be able to be mitigated, specifically with amivantamab lazertinib, but even chemo-OC. And we'll have to see how this pans out once potentially amivantamab lazertinib gets approved.
Now in the US, the FLAURA2 regimen of osimertinib chemo is approved. The MARIPOSA regimen of amivantamab lazertinib not yet approved. Right now, I think for a lot of people, osimertinib alone remains a standard, certainly outside of the US. Solange, what do we do after osimertinib?
What we do after osimertinib, first of all, is to try to understand what's happening there. So we have been describing using solid biopsy, tissue biopsy, or liquid biopsy, the various mechanisms of resistance. So as you can see, there's all of a range of potential mechanism of resistance to osimertinib, a very potent drug. For example, on target, secondary mutations, the C797S, you will hear about it, is a very tough mutation to target. But you can also have some very dedicated genetic changes that we know very well that are added and re-signaled through cell proliferation, MET amplification, sometimes ALK, BRAF, HER2, RET, being added to the original EGFR mutation. Looks very strange, but it happens. Sometimes you just have activation of what we call bypass tracks, other oncogenic tracks, which unfortunately just allow for the cancer cell to redivide. Sometimes you even have some plasticity, and I spoke before about transformation. Your adenocarcinoma becomes a squamous or a small cell, which of course cannot be seen in liquid, but changes how you can manage, and sometimes you don't know. So all of this category of resistance mechanism might define different treatment selections, that's for sure, from new EGFR inhibitors, what we call the fourth generation, but they are still in development, to strange combination, two TKIs together. It's a bit experimental, but sometimes we give alectinib and osimertinib, trying to hope it's not going to be too toxic, to basically go back to, chemotherapy or modern chemotherapy, which might be antibody-drug conjugates, but to the basis of the basis. So this is about osimertinib. We have the osimertinib combination. And when you don't have actionable genomic alterations, or when you don't know what is the mechanism, then you have to go back to the basis of chemotherapy, modern or less modern, with or without anti-angiogenic. Sometimes with immunotherapy, it's a matter of debate in EGFR, but you need to to use the backbone of chemo, right? So we are back to the old days because you don't understand what's happening there. So maybe just to give you some example of advances, imagine that the juice is not worth the squeeze, and you decide not to escalate immediately, so you just give osimertinib, as in the table before. Can you maybe use these drugs which are toxic somehow, or at least more than nothing, later on? So the answer is probably yes with Mariposa 2. So Mariposa 2 is you start with osimertinib, and at resistance, regardless of the mechanism of resistance, at that time you use amivantamab. So amivantamab plus chemo, amivantamab plus lazertinib plus chemo, a bit contraintuitive. You have resisted to osimertinib, but you continue EGFR versus the standard chemotherapy. Just one thing, the thought of keeping the EGFR TKI is to protect the brain. It was very logical at the time it was designed, the trial. This is a positive trial. So with or without lazertinib, amivantamab and chemo at resistance is better than chemo, and significantly better in terms of PFS, a bit like Mariposa 1. It's very convincing, right? What we would have expected is protecting the brain, so at least this lazertinib would have brought something. Not even. The amivantamab chemo, it was very surprising, does as well as continuing the TKI. So no real argument, and you have to know it was very toxic to give the 4 drugs. And it gave rise to VTE, thrombosis that were unexpected. So basically, yes, you can use amivantamab, but maybe only amivantamab with chemotherapy in that line of treatment. And then, of course, a good drug means you need to think about giving it earlier. And we are learning about it. The best treatment first, but also the best treatment as early as possible in the course of the disease. Now we do some screening, so we see more and more early disease, and you can perfectly document an EGFR mutation in a small biopsy. No need to do an NGS. You can just go for EGFR if you need to do that. And this is the ADAURA trial, which questions the idea of doing surgery in these patients, giving chemo according to your guidelines locally, but giving osimertinib versus placebo for 3 additional years. So very nice trial, which was mainly targeting stage 2 and 3, but also looking at stage 1. And as you can see, it's amazingly improving disease-free survival, but also amazingly improving survival. So this is a model for all this oncogene addiction in early disease, and we see new data coming down the road. And what I really found super exciting is this abstract presented, we just saw the abstract at this meeting, but showing that if you follow by liquid biopsy, we are refractory in Europe, but it's wrong, because if you follow by liquid biopsy, the patients who are under this osimertinib, it's interesting, most of the time it's fine, but when you stop the osimertinib at 3 years or because the patient decides to stop, very often you see, in more or less 30% of patients, you see the MRD, so the mutation re-emerging in the blood. And this is 5 months before your CT scan tells you there is progression. So that's very exciting because it paves the way of, first of all, following something else at the CT scan, but maybe when you see the little piece of MRD coming back, maybe you should restart your osimertinib. And it gives you kind of a modulation in the duration of osimertinib. So I find this data absolutely astonishing. I'm looking forward to see all the details about it. Early disease, we will also see on Monday, I guess, the second, the LAURA. So the LAURA trial is the same sort, absolutely the same sort, but it's after radiochemo. You cannot give surgery because of locally advanced disease or on inoperable patients. So you do your radical radiochemo sequentially or concomitantly as we prefer, and then you give osimertinib versus placebo. Criticism of LAURA, we know by press release that is highly positive. Criticism is osimertinib has no duration here. So it's a long treatment, so something to discuss with the patient. But I'm sure the benefit will be somehow similar, I would guess. No reason to change the biology. Neo-ADAURA is maybe the next step. You can give maybe all this in neoadjuvant. So the standard arm is placebo and chemo, so chemo in the neoadjuvant setting. We sometimes do it in stage 2, particularly in stage 3. But you can also give only osimertinib in the neoadjuvant, or you can give osimertinib and chemotherapy like FLAURA2. Then you go to surgery, and the endpoint of neo-ADAURA is, interestingly, the pathology. Major pathological response or pathological complete response. And of course, later down the road, you'll see how with the EFS and OS and the adjuvant, you can decide what you do. But very interesting to see maybe you can improve the resectability and the outcome if you do it before surgery. So neo-ADAURA is the last step to complete the picture. Then many questions to come. What about stage 1? Stage 1, very small disease, 1 to 2 centimeter, 2 to 3 centimeter. Is it worth giving adjuvant osimertinib? Courageous trial, ADAURA-2, is looking at this patient with osimertinib in the adjuvant setting. No chemo, of course. I have no indication, but osimertinib. And last but not least, Target is a phase 2 trial, which is exaggerating, you will say, but maybe it's right. 5 years of osimertinib. Do you need 3, 5, 7, or forever? So this is telling us by comparison, is 5 years in this Target trial better than the data we had with 3 years in the ADAURA trial? And I think it's very important because we struggle really with the duration of TKI in the adjuvant setting with no visible disease.
Yeah, hopefully the MRD will guide us. We'll see those data. We'll see the LAURA data tomorrow. Tremendous advances that we're seeing in this space. But to be clear, when we talk about Mariposa, we talk about Mariposa 2, we talk about FLAURA2, ADAURA. Our EGFR mutation here is the deletion 19, or that exon 21 L858R, but there are other EGFR mutations. Let me turn it to Jess. Can you walk us through exon 20 mutations?
Absolutely. So EGFR exon 20 insertion mutations, those are in about 4 to 10% of patients with EGFR mutated lung cancer. These are very distinct from the classical EGFR mutations that we were talking about, right? So demographically, patients with lung cancers with exon 20 insertion EGFR mutations tend to be similar to those with the classical EGFR mutations, but the treatment paradigm is entirely different. Historically, the EGFR inhibitors like osimertinib or lorlatinib, gefitinib that we've been talking about don't work as well for this subset of lung cancer. The first real exciting advance in terms of targeted therapy for exon 20 insertion mutations in EGFR came with the CHRYSALIS trial. This was looking at amivantamab, which Ben already covered. It's a EGFR-MET bispecific antibody. And in the CHRYSALIS trial, patients had already received platinum-based chemotherapy and then went on to receive amivantamab, and we saw a response rate 40%, median PFS 8.3 months. This was really exciting first advance in terms of targeted therapy for this subset. And you already heard about some of the adverse events we can see with this agent, including infusion-related reactions and MET and EGFR inhibition-related toxicities. We've seen longer-term outcomes with amivantamab in this subset, and I think that as we continue to make therapeutic advances here, we're going to see the survival shift for these patients as well. The second exciting advance came last year at the ESMO meeting. We saw the PAPILLON results presented. So this was now trying to move amivantamab into the first-line setting, right, for patients with newly diagnosed metastatic advanced lung cancer, EGFR exon 20 insertion mutations. Those patients were randomized to receive AMI plus chemotherapy versus chemotherapy alone, which was older standard of care. And the primary endpoint was progression-free survival by Beaker, and it was a markedly positive study. You can see the curve here, hazard ratio of 0.395, median PFS of 11.4 months now with AMI plus chemo, as opposed to 8.7 months with chemotherapy alone. And the objective response rate was also superior. They also looked at PFS2, which was also superior. So this is a regimen that is now considered standard of care as well for EGFR exon 20 insertion mutation. But now you might ask, what about oral EGFR inhibitors? Could they have a role here, or are we abandoning them forever? So, back 3 years ago, we were initially excited when mobocertinib received accelerated approval for this subset, but then last year we heard the news that the indication is being withdrawn because of the negative results from the phase 3 EXCLAIM-2 trial. But there is yet hope. We have the newer oral EGFR inhibitors that are showing really promising efficacy and reasonable tolerability for this subset of lung cancer. So we've seen data emerge for furmonertinib, sunvozertinib, and zipralertinib. And these are all studied in the later line setting, but a couple of them are also being studied in the first line setting. We don't have time to cover all of the data here today, but I think with regard to the ASCO meeting, really exciting data coming out for sunvozertinib. This agent is actually already approved, has received conditional approval in China based on the promising efficacy data. So in the treatment naive setting, we've seen response rates in the range of 78%, which is quite good activity for this subset of lung cancer. And at the ASCO meeting, we've seen data for patients with pretreated lung cancer where response rate was as good as 54%. So I think this is going to be a field that continues to evolve over the next year or two with these targeted therapies. We would like to cover the atypical EGFR mutations as well. So Ben mentioned earlier that EGFR mutations are actually genetically diverse spectrum of mutations, right? So we talked about the classical EGFR mutations, and we talked about the exon 20 insertion mutations. We shouldn't neglect what we call atypical EGFR mutations. So here we're referring to mutations like G719 substitution, L861 substitution, and others. This is another subset where we need better options. The only approved targeted therapy here is afatinib, and even though there is good activity there, afatinib is not the easiest drug for our patients, so we want to develop better options. This year, we're seeing data for AMI plus lazertinib from the Chrysalis-2 trial, and here response rate is 51%. Median progression-free survival in the treatment-naive setting, we just heard today, 19.5 months, which is super encouraging data from my perspective. So again, looking forward to seeing further updates in the future.
We've got a few questions here. One for you, Jess. Question here. Let's see. What do we know about the role of ADCs overcoming resistance? We didn't have a lot of time to go into these, but Jess and then maybe Ben, can you talk a little bit about the ADCs that are being used here and what role they're going to have?
Yeah, I think ADCs are really emerging options for patients with EGFR-mutated lung cancer post-targeted therapy. We've seen data for patritumab deruxtecan, HER3-targeted ADC for patients after osimertinib, and including CNS activity, actually, which options are really limited after osimertinib for patients with active CNS disease. We've also seen activity reported for TROP2 ADC with datopotamab deruxtecan, response rate after osimertinib of as good as in the 40% range. And so I think those are definitely therapeutic options that we're going to see incorporated into the treatment landscape going forward.
I think this is very well summarized. I think the only thing that I would add is that, the future looks bright for ADCs and EGFR-mutant lung cancer. I think we're just beginning to scratch the surface with patritumab deruxtecan and datopotamab deruxtecan. Some of these novel ADCs, these bispecific ADCs, these dual payload ADCs, encouraging data specifically in the EGFR-mutant patient population.
Solange, question here about brain metastases up front. Is there any role for radiation before systemic therapy?
This is a real question, right? We don't have randomized data really telling us the exact timing of giving radiation. It's really a kind of more of an habitude or tumor board decision, to be more scientific, and potentially also leads to the risk that lesions in the brain might give rise to. But basically, if you have these drugs, we will see all the ALK TKIs, but osimertinib and lazertinib are good examples of drugs which will treat the brain metastasis. So in patients with asymptomatic brain mets, you probably are allowed to give immediately or systemic treatment and wait for the response there. I know some centers prefer, if there's a limited number of lesions, to treat these lesions because they might also be the site of relapse later on due to pharmacokinetic differences, but basically there's no prospective data showing that, right? We've been seeing today amazing data, I invite you to go to see, about combining osimertinib and radiation. So you might be surprised that there are circumstances in which it's a very good idea, but it might be selection of patients and of course a discussion to have with your patients.
The next topic here is ALK, anaplastic lymphoma kinase. Jessica, maybe I'll go to you as I think one of the global leaders in this field. Can you tell us about how we target ALK?
Yes, there's a lot to talk about here, so hard to condense into just a few minutes, but ALK rearrangements, just really briefly, 3 to 5% of patients with lung cancer. Wealth of effective targeted therapies, but I think we're seeing more and more data emerge for next generation ALK inhibitors. So Ceritinib is one of them, and this is an agent that we don't really commonly use for patients with ALK-positive lung cancer anymore. Median PFS with Ceritinib in the first-line setting of 16.6 months. It doesn't quite get into the CNS as well as some of the other next-generation ALK inhibitors that we're going to review, and there can be pretty tough GI and hepatic toxicities, and so those are the reasons why we don't really use this agent as commonly anymore. The first real practice-changing trial was with alectinib as a second-generation ALK inhibitor, when it was compared against crizotinib, and that was when we started using next-generation ALK inhibitors up front. And with alectinib in the first-line setting, we see median PFS in patients with metastatic ALK-positive lung cancer of 34.8 months per investigator assessment. This is a CNS active agent where we see systemic activity in patients with and without baseline metastasis. And we've seen 5-year overall survival, estimated overall survival of 62.5% with this agent in the ALEX trial. Another approved second-generation ALK inhibitor, brigatinib, also compared against crizotinib in the ALTA-1L trial. And with brigatinib, we've seen median PFS in the first-line setting of 24 months per BICR assessment. You see here another long-term follow-up data, this time for brigatinib with a 4-year overall survival rate of 66%. And then another second-generation ALK inhibitor, ensartinib. This is an agent that's not approved in US, but is approved in China. But really just to drive home the point that with second-generation ALK inhibitors, we're really seeing consistent data for all of these agents in terms of the level of systemic efficacy, and generally all very well-tolerated agents. A big talk of the ASCO meeting in the past couple of days has been the 5-year follow-up data from the CROWN trial. Now, this is the trial where they compared third-generation ALK inhibitor lorlatinib against crizotinib, and we already knew that this was a positive trial in terms of the primary endpoint with the PFS. What was remarkable at this ASCO meeting is that after 5 years of follow-up, the median PFS with this third-generation ALK inhibitor lorlatinib remained not reached, and we saw a 5-year PFS rate of 60%. And so even though we don't have phase 3 trials that compared lorlatinib against the second-generation ALK inhibitor head-to-head, this is kind of the level of systemic efficacy that we haven't seen before with the second-generation ALK inhibitors historically in the other trials. So really exciting data. One of the key pieces of finding to look forward to in the coming years is going to be what does the resistance landscape look like for patients who do receive first-line lorlatinib, right? Because that is going to be critical for us in terms of thinking about subsequent treatment strategies for these patients. Dr. Solomon presented, was it just yesterday, some of the early data where none of the patients who did have early progression on first-line lorlatinib and had repeat biopsies were found to have an ALK resistance mutation. So really emphasizing that we are looking at off-target mechanisms of resistance, kind of in the same category that Solange highlighted earlier in the EGFR mutated space, and strategies there are going to be key. This is just showing that that level of PFS benefit is held regardless of the baseline CNS metastasis status. And then after 5 years of follow-up in the CROWN trial, no new safety signals observed with lorlatinib. However, it's important to remember that the toxicity profile with this agent is really unique. Hyperlipidemia, really common with this agent. Actually, over 60 to 70% of patients develop hypertriglyceridemia or hypercholesterolemia, so important to monitor. We see weight increase, neuropathy, mood and cognitive issues. Those are all distinct for lorlatinib. So it's really important to be aware of these, properly counsel patients, monitor, and dose modify when warranted. And it was really reassuring to see the data that's shown on the right-hand side, where in the CROWN trial, when patients underwent dose reduction within the first 16 weeks of therapy with lorlatinib, there wasn't a significant impact in terms of PFS or intracranial PFS. So very reassuring data to see in terms of managing those toxicities. There is a 4th-generation ALK inhibitor now in development that we're going to hear more and more about. This is called NVL-655, and we did see some early data presented last year where in patients who were heavily pretreated with ALK-positive lung cancer, including the majority of patients having received lorlatinib, there was encouraging activity that was noted with response rate, as you can see here, exceeding 40% in this patient population, also CNS active, and with an overall favorable tolerability profile based on the phase 1 trial data that we've seen. So this agent is now in phase 2 testing globally, and we're looking forward to seeing more data emerge. Now, I cannot not mention the ALINA trial, right? So this was one of the key trials last year, also presented at the ESMO meeting. And so you heard earlier from Solange about the ADAURA trial in the EGFR mutated lung cancer space. In ALK-positive lung cancer now as well, for patients who undergo surgical resection for early stage disease, we have a targeted therapy option in the adjuvant setting. So this was the ALINA trial where patients were randomized to receive alectinib versus adjuvant chemotherapy. So there is a difference in the trial design here compared to the ADAURA trial. And the treatment with alectinib here was for up to 2 years, not 3 years as you saw with osimertinib in the ADAURA trial. This was a markedly positive study. You can see the DFS curves here for stage 2 to 3A patients on the left-hand side and the ITT population on the right-hand side. So it is now standard of care to give postoperative alectinib for patients who undergo resection of early-stage ALK-positive lung cancer. Key point being that the practice change that you saw with EGFR mutation a few years ago, it is a concept that can be more broadly applied against in other oncogene subsets of lung cancer, and also emphasizing that those gaps in biomarker testing that we discussed earlier, we really have to address that, because now, even in early stage disease, biomarker testing for these genomic alterations is going to become increasingly important. Let's talk a little bit about, what do we do in the neoadjuvant space for patients who have resectable lung cancer with ALK positivity. So here we don't have data yet to support routine use of neoadjuvant alectinib. However, Nautica-1 trial is assessing this question. And the very early data that we've seen have been very promising. We've seen data for only 9 patients so far, but there is actually a path CR rate of 33%. So in EGFR space, when we look at neoadjuvant osimertinib monotherapy, data have been actually not that compelling. Path CR, we really don't see achieved at all. In ALK-positive lung cancer, is the biology a little different? Is this going to hold up with larger numbers of patients? That's a question that remains to be answered.
So we got a few ALK questions, and maybe I'll give them to our colleagues on the edges here. First question here, what would you do after chemoradiation for an ALK non-small cell lung cancer?
Well, I guess we first have to see the LAURA data, but I think it was really nicely suggested, the idea that at least in these diseases where the TKI is very efficient, maybe also goes to the brain, so efficiency and also brain protection, the ADAURA has paved the way to, I wouldn't say a generalization, but maybe a concept that might be applied across oncogene alterations, genomic alterations, which are highly actionable according to the scale. So it's EGFR, it's ALK, it's ROS, it's RET, it's probably BRAF. So all of these diseases should be considered, and track should be considered maybe to be treated the same way without needing a crazy randomized trial. So to answer Laura, I wait to see the results, but once I will have seen the result, would I have the opportunity, I would discuss with my patient to apply the same concept of consolidation. We don't call it adjuvant, but consolidation, osimertinib, alectinib, lorlatinib, whatever TKI you'd like to, selpercatinib, in the idea of reproducing the same mechanism of action.
Ben, this is kind of a sophisticated question, actually. We talked about ALINA, adjuvant alectinib. The question here is, do you need chemotherapy?
I think, for better or for worse, the ALINA was designed comparing alectinib versus chemotherapy. I do believe that we still need chemotherapy for our patients. We need to remember that chemotherapy provides an overall survival advantage for patients with resected 1B to 3A, albeit modest. So I would extrapolate here from the LACE meta-analysis and ALINA, and for those patients that are 1B to 3A, specifically maybe 2 to 3A, I would offer adjuvant chemo followed by alectinib.
Jessica, adjuvant chemo, yes or no?
Yes, adjuvant chemo.
Solange?
No doubt, yes.
I'm not sure. I don't know. I'm not sure that, I think it might be a drop in the bucket. Let's move on to ROS1 as our target here. We've just, I'm going to turn it back to you, pulling double duty here, leaning on you to walk us through ROS1.
Yeah, let's talk about ROS1. It's in 1 to 2% of patients with lung cancer. We have highly effective ROS1 targeting therapies available, so let's chat. Up until recently, we had 2 FDA-approved ROS1 inhibitors, right? These were crizotinib and entrectinib. Crizotinib, ALK ROS1 MET inhibitor. In patients with metastatic ROS1 fusion-positive lung cancer, we've seen really good activity, median PFS in the 19 months range. Entrectinib, ROS1 NTRK inhibitor. In patients with ROS1 fusion-positive lung cancer, we've seen median PFS of about 19 months. The key difference between the 2 agents being that entrectinib has shown CNS activity in patients with brain metastasis. Crizotinib, really not an effective agent in terms of crossing the blood-brain barrier. The key change in this treatment landscape came last year with the TRIDENT-1 trial. So this is worth spending a few minutes on. TRIDENT-1 was the global phase 1/2 registrational trial. This was looking at a next generation ROS1 NTRK inhibitor, repotrectinib. So we're going to come back to repotrectinib later in this session. So in this section, we're talking about ROS1 fusion-positive lung cancer. And repotrectinib in TRIDENT-1 was evaluated in patients with TKI-naive ROS1 fusion-positive lung cancer, as well as TKI pretreated ROS1 fusion positive lung cancer, okay? So in patients who had TKI naive lung cancer, you can see the waterfall plot here, right? The data speaks for itself. Response rate of 70%, duration of response quite long there. But the money curve is this PFS curve. So we saw a median PFS of 35.7 months, which is quite different from what we've seen historically with crizotinib and entrectinib, right? Where the range was more in the 16 to 19 months. And then overall survival data is still immature in the Trident-1 trial. In terms of the pretreated ROS1 fusion positive lung cancer patients, here also was activity. So response rate of 38%. And then CNS activity as well. This is a CNS penetrant agent. These are actually intracranial PFS curves for TKI naive and TKI pretreated patients, and quite good curves, right? So repotrectinib, based on these findings, actually became the first targeted therapy to be approved for patients who have received prior ROS1 inhibitor. But the label is for line agnostic use. And so based on the compelling PFS data in the TKI naive patient population, it is approved to be used in the first line setting as well. So this is the first next generation ROS1 inhibitor to be FDA approved. And I think over the coming years, as you will see soon, we're going to see more and more next generation ROS1 inhibitors enter the treatment landscape. At this ASCO meeting, we're seeing an update on the Trident-1 data for TKI naive patients with repotrectinib. And the key piece of information here is that the level of systemic efficacy that we've seen, as well as CNS efficacy, are really holding up nicely with longer follow-up. So this is approximately 1 more year of follow-up compared to what we saw last year, and no big change in terms of the PFS and duration of response data. I mentioned that there are other next-generation ROS1 inhibitors that are entering the landscape. One of those is taletrectinib, and this is an agent that's been highlighted at this ASCO meeting. So taletrectinib is also a next-generation ROS1 inhibitor, and we've seen data reported previously prior to this ASCO meeting from the Chinese phase 2 trial called TRUST-1, and we had seen this really compelling response rate data of 93% in TKI-naive patients, and also activity in the TKI crizotinib pretreated patients with a response rate in the 53% range. This is an agent that has activity against one of the most common ROS1 resistance mutations that we can see in patients who receive prior crizotinib or entrectinib. That one is called G2032R, and taletrectinib does have activity against that mutation. Now, these are the data that were just presented today at the rapid oral session. So updated data from the TRUST-1 trial, where we saw that the response rates basically held in both TKI-naive and crizotinib pretreated patients. What's remarkable is the median PFS data again. So really different from what we've seen with crizotinib and entrectinib. Here, median PFS per blinded independent central review assessment has not yet been reached. Now, the manuscript has now been published as of today in Journal of Clinical Oncology. And if you look at the data in the manuscript per investigator assessment, median PFS was about 31, 32 months. So more in line with what we've seen with repotrectinib in the Trident-1 trial. So I do think that next generation ROS1 inhibitors are actually performing better in terms of resulting in longer duration of response in these patients. This is also a CNS active agent. And then there is a global trial, phase 2 trial that is ongoing called TRUST-2, also looking at taletrectinib. So the prior data was from the Chinese phase 2 trial, and I think it'll be nice to see those findings affirmed in the global population. So far, there's no reason to believe that the data should be any different. We've seen very early data reported from the TRUST-2 trial, and you can see that the objective response rates basically recapitulate what we saw earlier in the Chinese phase 2 trial. Let's talk about NVL-520. This is another next-generation ROS1 inhibitor that was designed to be highly ROS1 selective and also TRK sparing, because some of the available ROS1 inhibitors also inhibit TRK, and what that results in is some of the less desirable TRK inhibition-related neurologic toxicities, like dizziness, like paresthesia, and weight increase. And so that's why the drug was developed to be TRK sparing, and we've seen data from the phase 1/2 trial, ARROS-1, where there was very nice activity reported, as you can see in the waterfall plot and the table here, in patients who had received multiple prior ROS1 inhibitors, including in patients who had received prior repotrectinib, actually, and in patients who had received prior lorlatinib. This is also a CNS active agent, and CNS responses have been reported. We cannot neglect lorlatinib. Stephen already mentioned this. This is data that was just presented earlier today in the rapid oral session. So lorlatinib, we talked about a lot as an ALK inhibitor for patients with ALK-positive lung cancer. It's actually a dual ALK and ROS1 inhibitor. And so there was a single-arm phase 2 study that evaluated lorlatinib in TKI-naive patients. We already knew that lorlatinib demonstrated activity in TKI pretreated patients. That has already been published. And so in this study, response rate was 69%. What was remarkable was the PFS. So during the presentation, it was mentioned that the median PFS was in the range of 54, 53 months, which is really interesting finding, right? It's a very long PFS. So it'll be nice to see if that really holds up in larger patient population. Adverse event profile, very consistent with what we've seen in patients with ALK-positive lung cancer. No surprises there, hyperlipidemia, weight gain, paresthesia, and so forth. This is a treatment landscape that's going to continue to evolve very fast in the coming year or two. So it's worth watching out in that space for more news.
So my understanding in that lorlatinib is not an FDA-approved ROS1 inhibitor?
That's right. As of right now, the FDA label is for patients with ALK-positive lung cancer.
We've got some fairly direct questions, so maybe I'll just throw this to you, Ben. Ben, should we sequence repotrectinib after entrectinib, or should we start with repotrectinib?
Yes. Yeah, I think we just don't know. That I'm of the mindset, use your best drug first, potentially. And that really is compelling data in the first line. We need to remember also, as Jess mentioned today for ALK in her discussion, her wonderful discussion for the Crown, not everyone makes it to second line with these genotypes. So this is compelling data for me to consider using it in the front line.
I'll take one more ROS1 question here. Jess, more of a practical one. What do you do with weight gain? Should we use Ozempic?
I cannot recommend that today. There is no evidence, hard evidence that we have right now to just go ahead and reach for GLP-1 agonists or other medications to control weight gain with lorlatinib. If there is a FDA-approved indication to use those medications, then absolutely. Anecdotally, I have heard that there have been some results with using that to ameliorate the side effect, but there hasn't been any specific trials dedicated to answering that question for patients with cancer treated with lorlatinib.
We move on to an emerging but fairly rare target, that's NRG1 fusions, NRG1 neuroregulin 1. This is a massive gene, and this actually represents the ligand. It's a very interesting target, but for the sake of time, I'll mostly mention that NRG1 fusions are really hard to find. To find an NRG1 fusion, you really do need RNA sequencing. It's a massive gene, mostly intronic. You've got a classic non-smoker, younger, not responding to frontline therapy. If they've had DNA-based testing, you might be missing these NRG1 fusions. We know they do not respond well to chemotherapy or immunotherapy, but there is a new agent being developed. This is zenocutuzumab, a HER2/HER3 bispecific antibody. And when we look at the energy study, we can see that the RECIST response rate 37%, but the clinical benefit rate north of 60% with a median duration of response of almost 15 months. This agent given intravenously showing clear activity, not yet FDA approved, but one to keep an eye on. This is another target we need to test. Let's turn to one that's a little bit more common, but still relatively rare, and that's RET, or rearranged during transfection. Let's go on to RET. So what do we do for RET fusion positive non-small cell lung cancer, Solange?
Very nice. Thanks so much. We speak selpercatinib, and maybe here we can just introduce in 1 second a concept we have no time to discuss, but it's the tumor agnostic kind of biomarker where you can apply the same drug. We have been seeing it with ROS and ALK for some compounds, but here, thinking about another organ, you can use a selpercatinib in the thyroid cancer. So we have been seeing that, and that's a new concept. Regulators have difficulties with the concept, but we have to move this concept forward for these diseases which are driven by the same oncogenic pathway and can benefit from the same drugs. So selpercatinib is one of these drugs. Remember, RET is rare also, let's say 1-2% of non-small cell lung cancer. This is a rearrangement. So again, you need an RNA, DNA testing in terms of genetic, in terms of NGS. Reason why circulating doesn't work, because the RNA is degrading in the blood. So that's why maybe Europeans are right, tissue is better. You might lose 30 to 40% of this diagnosis if you go into the blood, or if you go just for DNA, as some people do. So let's be careful, we might miss some of this. This is the phase 1/2 trial, one with expansion of the selpercatinib in this patient with treatment-naive, RET fusion positive non-small cell lung cancer, but some have received chemo. So basically on the left-hand side, you can see that in this patient having received chemo, a wonderful response rate to selpercatinib in this early trial was 61%. a kind of interesting duration of response in this patient, the first 170 patients who were treated. But when you think about this patient who just got the diagnosis and are treatment naive, no chemo, nothing, the response rate goes up. And that's something we observe in many of these oncogene addicted non-small cell lung cancer, because probably of clonal divergence, a more, I would say, intact and clonal tumor responds better. And here the response rate goes up to 84%, so almost never reached, and you've seen the curve. So basically here you have all the numbers about previous platinum or treatment naive, but everything is improved, particularly response rate, and to a certain extent, maybe PFS and OS are slightly better in treatment naive, but still excellent, even in pretreated patients with chemotherapy. So if you have not had the diagnosis initially after platinum-based chemo, it's still an excellent option. And the CNS progression, answering your question before, is very strong with an improvement of all the, I would say, impact of CNS progression or even the treatment of metastasis present at baseline. So really a very brain penetrant and active drug for RET non-small cell lung cancer. So based on this data, you will ask me, well, you have your answer. Why would you randomize selpercatinib versus chemotherapy? Because the regulator said, maybe it's a bias, you have selected your patients, we don't know, do a phase 3 trial. So a phase 3 trial, selpercatinib versus chemo, or even maybe versus chemo IO, matter of debate. The regulators wanted it. Is it useful? I don't know, but it was needed. So it's about, as you see, randomizing 2-to-1 selpercatinib is better than nothing. 2-to-1 selpercatinib versus chemotherapy. And in these trials, they wanted to have the control arm the best as possible. So they allowed for immunotherapy and even wanted to have a certain proportion of patients receiving the immunotherapy, up to 80%. So really to make sure not to get another criticism, right? Enough is enough. So they did run this trial, of course, with the primary endpoint of PFS, because there was this idea of permitting a crossing over, giving at least selpercatinib later on, otherwise it's really unethical. And basically, as expected, because nothing is invented, you have an absolute benefit, hazard ratio 0.4 something in the patient receiving pembro chemo, and in the whole population, same thing. So pembro probably doesn't change anything, but still you had the best ever control arm you could have, and it changes the paradigm. Quite interesting, this led to a discussion about the notion of equipoise. Should we still randomize our patients in trials where you know the answer even before you start in terms of toxicity, efficacy? Probably not. Maybe this control arm with chemo or chemo-pembro could be synthetic based on real-world data. So that's a matter of debate. But of course, we are subject of the requirements from regulators still. This is, so of course, you have all these subgroups. And just to make a long story short, all the subgroup benefits, particularly the patients with brain mets, patients from each of the continents. So there's no limitation in this trial efficacy. We have an update at this meeting showing some more data looking at the brain in patients with or without brain mets, really covering the idea that irrespective of the presence of brain mets, the selpercatinib is way better than chemo, even slightly better when you have brain mets. And importantly, in terms of quality of life, using the usual criteria, not optimal, but still you delay the deterioration of the symptoms and you improve the quality of life of your patient. So everything is improved, but unfortunately it was expected. We have one competitor, the pralsetinib, which was really running side by side with selpercatinib, but for many reasons, particularly development reasons in terms of the pharma industry and maybe the investment made around the drug. This drug, the pralsetinib, which was giving rise to very similar response rate in treatment naive, as you can see, 72% response, in pretreated patients, 60%, so something very similar. This has gone through various changes in the markets, right, and is now way less available and probably doesn't have the phase 3 trial. And the phase 3 trial was started but stopped, so maybe the level of evidence, as we say, will remain lower. So now that we have made the exercise, let's at least give it a value which is selpercatinib prescription. And here it's quite interesting to see that there is a new compound, the EP0031, which is in phase 1. It's a new, very specific and selected RET inhibitor, which might be very efficacious in patients naive from treatment, but also at resistance. It's a phase 1, so it shows promising activity, a very good safety profile, by the way. These compounds are quite well tolerated, but selpercatinib has some side effects, so something to see, and we have to stay tuned, of course, in naive patients, but maybe, who knows, to follow as a sequential treatment after resistance for the first one. Last but not least, some regulators are regulator, ADAURA trial, ALINA trial. Now we go in something 1% non-small cell lung cancer. Do you really need to randomize selpercatinib versus placebo after surgery in this patient having received chemo or not? Yes. It's being done, it's being conducted. You will have to screen thousands and thousands of patients to know if selpercatinib is useful in the adjuvant setting, and it's now being done, and we hope for the results to be seen not tomorrow, but probably in some 1 or 2 years from now. So main question is, should we really do that?
So an important target, again, they don't respond well to immunotherapy, and we also know from before that if we give immunotherapy before these targeted agents, it is much more toxic. We have 2 FDA-approved drugs here, pralsetinib and selpercatinib, and we're just going to move right into our next session, which is HER2. But first, when we think of HER2, I think most of us in the oncology space know HER2, but it means different things in different diseases, right, Ben?
Yeah, absolutely. And in lung cancer, I think we know it's the HER2 mutation that matters, not overexpression or amplification. That's important. Clearly the therapeutic landscape for HER2 mutations has evolved. The only antibody drug conjugate currently approved in non-small cell lung cancer is trastuzumab deruxtecan, specifically for HER2 exon 20 mutations. I think we all know ADCs is a monoclonal antibody, a linker, and a payload. Here, the payload is a DXD. Really important, topoisomerase inhibitor we know is active in lung cancer, so seems reasonable to exploit this compound. The first data set that we had was the DESTINY-Lung01, and specifically in cohort 2, which was EGFR-mutated lung cancer patients. We saw competitive response rates in second line and beyond, and durable responses. And this was given at the 6.4 mg IV Q3-week dose. I think what we found out from this study was that there was a high rate of ILD, and that really forced another study, the DESTINY-Lung02, looking at the 5.4 mg per kg dose compared to the 6.4 mg per kg dose. This was a study, again, looking at 2 different doses, specifically in HER2 mutated lung cancer, advanced stage as second line. And importantly, there didn't seem to be a lot of difference in outcomes, but there was a lower rate of ILD. So we need to remember that the New England Journal of Medicine paper from Bob Lee was 6.4 mg per kg dose, but it really follow-up with the DESTINY-Lung02 is the 5.4 mg per kg dose. And again, you're seeing here the toxicities and the rates of ILD being much lower at the 5.4 mg per kg dose. And very similar outcomes here between the 2 doses. We look at the HER2 overexpressing cohort from DESTINY-Lung01, not really seeing a small number of patients, but at least in the high expressors, IHC3, there was a reasonable response rate around 50. I just don't think we know yet if IHC is going to be the predictive biomarker for trastuzumab deruxtecan, specifically in lung cancer, although we now have a pan-tumor approval for trastuzumab deruxtecan for overexpressing patients with overexpressing tumors. There are other agents in development. I'll just focus on one, zongertinib, funny name, but a fine-looking drug, looking at it as monotherapy in HER2 mutation-positive patients. I think this was presented earlier today, showing really nice response rates, a very well-tolerated drug. So I think this drug is gonna make it. I know there's other studies that are going to forward this drug, but it looks quite good and clean and well-tolerated.
I think Ben's gone through that quite well. Let's take one of these audience questions I think is pretty relevant. Ben, you went over DESTINY-Lung02. That was in the second-line setting. Jessica, should we be using these drugs earlier?
That's $1 million question. Right now, with the FDA label being in the later line setting, in my own practice, I'm still reserving it for second line. But there's still, there's certainly an appealing reason to consider it in the first line setting with that response rate.
And there is a phase 3 ongoing.
There's a phase 3 ongoing. Here's another question, a good one here. What do we know about brain responses with trastuzumab deruxtecan, Solange?
Well, surprisingly, again, a bit like, these big molecules which are hydrophilic, which should not penetrate, go through the blood-brain barrier by nature and by biology and biochemistry. Amivantamab before, and now there's antibody drug conjugates, huge molecule with a payload on the back. they all have amazing activity in lung cancer, in breast cancer, in this patient with brain metastasis. We try to understand why. Is it immune-mediated, or is it just because the barrier is more fragile than we would have supposed? But anyway, they all show surprising responses. So of course, we would love to have dedicated subgroups, phase 2 and trials to make sure we describe it correctly, but still, it's at least not an exclusion criteria, and it's way better than the old days, platinum, whatever combinations. So it's really a hope for the patients, even in late lines where sometimes brain mets are often are encountered.
Yeah, a pleasant surprise, I think, in seeing those data in the CNS efficacy. Let's turn to BRAF. There are many BRAF mutations and new drugs along the way. Solange, can you tell us how to treat a BRAF V600E mutant non-small cell lung cancer?
So here we have been learning from melanoma colleagues, right? This is a MAP kinase pathway, and activation which gives rise to a complex mechanism but very strong activation of the oncogenic pathway with melanoma V600E or lung cancer V600E. We maybe remember from the past it was vemurafenib that was used, but as monotherapy, just blocking BRAF, but giving rise some complications, particularly skin problems. So vemurafenib was combined with a MEK inhibitor, and in lung cancer we did favor not a dacomitinib, but the dabrafenib, trametinib, which is another combination, BRAF, MEK inhibitor. So having both together is very important to prevent a kind of feedback loop in the MAP kinase pathway, which can give rise to many side effects, particularly at the skin level. So you need both. MAP kinase pathway is difficult to inhibit. So dabrafenib, trametinib in this specific V600E mutation has been tested, and now we have a long-term follow-up of this trial. As you can see, the response rate is more or less 70%. The progression-free survival is 11 months, so a very good TKI, and overall survival of 25 months. This is a treatment that now, at the 5 years update, we are convinced should be given frontline in these patients. It's something which penetrates the brain and can really be a matter of debate in smoker patients because immunotherapy might also have a role, but very often is used frontline. You raised a very good point, is about other mutation. I have another BRAF mutation. Maybe I will use dabrafenib, trametinib. No, you should not, because the other mutations are very tough. And at the time being, to make a long story short, we don't know how to treat them. So this is about the next generation. Again, our melanoma colleagues, after vemurafenib combination, dabrafenib, trametinib, they had to try to find maybe a little better tolerated, but also options that work at resistance. So in melanoma, using this new compound, encorafenib, binimetinib, it looks like it might even be useful in patients being resistant to dabrafenib, trametinib. Of course, in lung cancer, we jumped on that. A bit slower, because remember, half of the melanoma patients have this mutation. In lung cancer is 2%, so we are slower. But it's just testing here, this PHAROS trial, the response rate of encorafenib, binimetinib in patients naive from treatment or previously treated. And as you can see, in both cohorts, having received chemo before or not, the response rate is maybe comparable to dabrafenib, trametinib, maybe slightly better. This will, of course, be the subject of indirect or maybe direct comparison. I would rather say indirect, but basically, we have this nice data now. You can see here in treatment naive a PFS of 20, PFS, sorry, I can read until which were not reached, but probably slightly nicer curves that we've seen with dabrafenib, and a PFS of almost 10 months in the previously treated. What is very interesting is still wait for some data to see if it works at resistance to dabrafenib like lung cancer, like melanoma, sorry, but we have not seen this data yet in lung cancer. So basically, the toxicity is very comparable with dabrafenib, trametinib. It's a toxicity that can touch the GI, of course, fatigue, but nausea, some diarrhea, and some hematological toxicity, mainly anemia, but basically well tolerated, and I would say probably slightly better than the previous combination. So we need larger number. Be careful, PHAROS is a small trial at the time being. We don't have the follow-up, and we don't have the numbers that we had with dabrafenib and trametinib.
Excellent. I'll reinforce a couple points you made there. The combination better tolerated than monotherapy. Sometimes I'll see people say, well, we'll start with dabrafenib and add trametinib afterwards. Really the wrong approach. The combination better tolerated than one drug alone. Encorafenib, binimetinib, really not seeing as many fevers as dabrafenib, trametinib, but importantly, the current approval is not to overcome resistance, really, but another option to use up front. But let's move on to MET. Ben, can you tell us about MET and lung cancer?
Yeah, I would say, just whittling it down, we have 2 drugs approved and 2 drugs on the move. And so capmatinib and tepotinib are both approved. They're showing competitive response rates in first line and in the refractory setting. And I think my choice would be use one of these drugs when identifying MET exon 14 skipping alterations. Again, we need to remember MET exon 14 skipping alterations, that is the defined biomarker. It's not MET overexpression or MET amplification, at least for now. This is, I showed you the capmatinib data and the tepotinib data. Savolitinib, a drug potentially on the move. Yes, it's been looked at in MET exon 14 skipping mutations, showing response rates that look quite nice, but certainly being exploited in patients with MET overexpression in the patients in combination with osimertinib in patients who've already received osimertinib. We were fortunate to present to be a part of this trial and really seeing some nice responses and durable responses with the combination of savolitinib and osimertinib. And then an ADC, an antibody drug conjugate, or maybe not MET exon 14 skipping alterations, but c-MET high or overexpression may matter. And this is data looking at both c-MET high and intermediate, and it seems like c-MET high may enrich for responses for telisotuzumab vedotin, again, a MET-directed ADC.
We're running out of targets. We've got a couple more to cover, and one of them is TRAC. Now, Jess, you talked a little bit about TRAC, and we were talking about ROS. Can you walk us through TRAC and targeting that?
Yes, so we have two approved agents, TRAC inhibitors, actually for solid tumors with TRAC fusions. Larotrectinib is one of them. Very well tolerated drug long term. You can see the waterfall plot here, median PFS of 33 months. The other agent is entrectinib, which we talked about in the setting of ROS1. Again, a very good efficacy systemically. Both larotrectinib and entrectinib have shown CNS activity. A drug on the move is repotrectinib. This is next-generation TRAC inhibitor undergoing FDA review right now, actually. It's shown activity in TKI-naive and TKI-pretreated patients with TRAC fusion-positive lung cancer, including those patients with TRAC resistance mutations.
We're going to move right again to our last topic here. Let's move on to KRAS and lung. When we think of KRAS and lung cancer,
so I had the opportunity to speak about BRAF, so we are exactly in the same pathway, right? The MAP kinase pathway with this difficult to target mutations. We have started all oncology, I guess, with this paradigm that you can target everything but not KRAS. KRAS is not a TKI, right? It's based on a GTPase activity where the affinity for GTP is so high that nothing can compete with this KRAS binding GTP. It's impossible, the affinity is too high. So what can we do? Nothing. It's not true. So KRAS mutations, first of all, on the left-hand side, it's a New York memorial series. On the right-hand side, it's a German series. Same thing, basically showing that there are various KRAS mutations which constitutively activate this GTPase hydrolysis. In lung cancer, it's mainly KRAS G12C that we observe, but unfortunately, we also observe the other one. Remember that KRAS G12C is observed most of the time in smoker patients. Why do I say that? Is because in this patient population, immunotherapy works very well, very, very well. So never forget that the first-line treatment of this patient remains the same first-line treatment as patient without oncogene addiction. So chemo IO, the usual paradigm of non-oncogene addiction for the KRAS G12C. That's not true for the other KRAS mutation, by the way, G12D, for example, in very often seen in never smoker patients. So here you have to have a bit more of a discussion with the patient about the unknown. But the G12C is the most common variant. It's seen in up to 13% of lung adenocarcinoma, which is a huge patient population as compared to what we have been seeing before, the NTRK and so on, right? So basically, it was not druggable until the moment we decided maybe not to block this GTPase, but maybe to block and lock the an active form of the KRAS. So it cannot be recirculated and activated constitutively or upon stimulation. And this changed the paradigm of not being druggable, and now it's druggable. So we had drugs, and we have lots of these G12C inhibitors being developed in competition, one after the other one. So the first one was sotorasib. So Codebrake 200 was the proof of concept. And in this trial, the sotorasib was used in patients, of course, pre-treated, in most of the cases with chemotherapy, sometimes in late lines. The response rate was in the 40% range, which is good, and a duration of response of almost 1 year. So this was druggable, right? And it's quite interesting that we went rapidly in the second line, compared it with docetaxel. And as you can see here, as compared to docetaxel, there is a benefit of this sotorasib versus docetaxel. So benefit is modest, right? And to be very, I would say, careful about what I can say here. It's modest and has been questioned by the regulators, maybe a little less by the scientific community because we like to have targeted therapies, but still the benefit is considered to be improved, right? We still need to do better with this compound. Interestingly, some activity of this sotorasib has been seen also in the brain, not really the trial to measure it because only patients with treated brain mets could be enrolled, but some signal of maybe even an activity at the brain level could be detected. Problem with sotorasib, the activity in the brain might be still weak, and the other thing, it combines very badly with immunotherapy. It gives rise to hepatotoxicity, and when you combine with a checkpoint, it becomes almost kind of not a thing to do, right? I would say discouraging and even dangerous. Okay, this is the waterfall plot. You can see really that sotorasib visually is better than docetaxel, but unfortunately, the survival curve was not really sufficiently, I would say, different not to open the debate. There were some problems also on the clinical trial conduct. So remember, sotorasib is the first step in a very long way, which you will see will be augmented by many other compounds, right? There were some attempts also to combine sotorasib with chemo to know if it's feasible, but as I told you, KRAS is immunosensitive, so you'd like so much to add a checkpoint here that it might be that this strategy will not be pursued, but it's interesting to see that this KRAS inhibitor can be combined with platinum-based chemo. But of course, you'd like to see a checkpoint in these strategies. Maybe that's something to do in negative PD-L1, but still something to think about. Okay? Second compound in the range, adagrasib, I wouldn't say second generation, it's just the next in line. Difference of adagrasib versus sotorasib in the CRYSTAL-1 against the early phase trial in second line. Very similar waterfall plot, very similar response rate between 40 and 50%, 43%. Side effect, maybe slightly less hepatotoxicity, and interestingly, you'll see it later on, this can be combined with immunotherapy. But basically, the profile of the drug was quite similar to sotorasib. I wouldn't have sent so much differently. The intracranial activity could be seen in CRYSTAL-1 because some patients had brain mets untreated but asymptomatic. And here you could see that it works in the brain, probably better than sotorasib, with a nice activity in the brain level in terms of PFS and overall survival in this patient who had brain mets at baseline. And what is quite interesting is it has a CRYSTAL-12 trial, adagrasib versus docetaxel in these patients with KRAS G12C mutation has been presented today. So think about it. Is it very different from the one I have shown with sotorasib versus docetaxel? Slightly. The hazard ratio is slightly better, but I mean, we are speaking about very important nuances when you look at inter-trial comparison that might not really be relevant in the daily practice. So response rate is way better. It was also doubled in the sotorasib trial, and basically the safety profile has no surprises. So you go from 3.8 month PFS to 5.5. Of course, in the trial, what you'd like to see is survival benefit, probably will not. You know what? Because there was a crossing over. So this is not a trial which will allow you to answer really on the magnitude of your effect on survival, which is fair for the patient, but the difficulty for the clinical comparison. CRYSTAL-7 is just the proof of concept that adagrasib can be combined with pembrolizumab. It has given even rise to amazing response rates, 63% not in early lines. The patients can have been pretreated in this trial, and a PFS which was not reached, but as you can see, very durable responses. So this can be combined. And sorry, it was all in treatment naive. There was no patient pretreated. This response rate is really something leading to very interesting prospective ideas of going frontline with this KRAS and immunotherapy. So we have another one, the olomorasib, which is another compound from another company, which was tested in two circumstances, in patients all comers, but KRAS inhibitors naive. Median PFS was 7.9 months, but what I like in this compound, it was tested in patients who were treated with another KRAS inhibitor, and here the response rate was 41%. Think about my BRAF, this may be a second-line KRAS also, so it shows it's more potent, and it prevents some, at least, of the mechanism of resistance. So quite interesting. There are also data of olomorasib with pembro. Response rate 77%. So again, it's naive patients, but very nice, 77. In pretreated patients, that's in this cohort you have pretreated, it's 40%. So very interesting, and this will be developed in the SUNRAY-01 trial, where patients receive chemo, IO, plus the KRAS inhibitor. If you have high PD-L1, you can even skip the chemo. The investigator can decide, as compared without the KRAS inhibitor. Primary endpoint PFS, secondary endpoint OS. It's going to be a very interesting trial. And of course, we have other compounds. This is a compound from another company showing again a very this new generation, a compound going to the brain, a compound which gives response rate rather in the range of 60-70% than we saw with sotorasib. But I heard that this compound development is a little slowed down. It might even stop. So maybe that's not the slide you should look at the longest time. But this is a compound from a big company, so divarasib, a New England paper, which was showing again very nice efficacy in these patients that harbor KRAS G12C mutation. It will also go frontline with a PFS of 13 months. In this patient, it was an early trial in late lines, so very interesting compound. So you have at least 3 compounds which will potentially push a little bit the sotorasib and adagrasib in the future. One word about it. There are new generation of KRAS inhibitors that target the other KRAS mutations, particularly for pancreatic cancer, think about it, which have another mechanism of action. They are allosteric, so they even bind differently. And there are also these new inhibitors that might be sequenced at resistance. So there will be second, third generation KRAS inhibitor to come in the future.
Outstanding, you guys, 90 minutes. That is on the nose. We've covered all of targeted therapy for non-small cell lung cancer, but the field is moving so quickly that next year we're going to have more agents. Probably not going to be able to do it in just that 90 minutes, but an exciting field. We've got to test, though, first. We'll reinforce that. None of these are options unless we find the targets. Having the targets not enough. We have to detect it and act on it. We'll be happy to take questions afterwards. I'll also provide Dr. Levy's home number if there are questions for later. But that brings us to the end of this session. Thanks so much for joining us.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, LUNGevity Foundation. This activity is supported through independent educational grants from AstraZeneca, Bristol Myers Squibb, Janssen Biotech Incorporated, administered by Janssen Scientific Affairs, LLC, which are both Johnson & Johnson companies, Lilly, and Novartis Pharmaceuticals Corporation. To access all materials for this activity, visit peerview.com/TFK860.